Hello everybody, I am Dr. Loveleen Mangla. I am working in Metro Center for Respiratory Diseases at Metro Hospital, Sector 11, Noida. I am talking about interventional pulmonology today. Interventional pulmonology is a subspecialty of a pulmonary medicine department. It is one of the growing field in the Indian and the world also outside. It basically deals with all the minimal invasive procedures for diagnosing and treating neoplastic and non-neoplastic diseases. In interventional pulmonology, we go inside your lungs, we evaluate your airways, your lungs, and also the pleura, which covers your lungs. The IP guy, what we famously call them, interventional pulmonologist guys, they may go inside through the endoscopes, like called as basically bronchoscopes, and pleuroscope to evaluate the pleural cavity. We have different types of instruments to evaluate your airways for different procedures and for different needs. In bronchoscopes, we have these are the basic things which were developed by Ikeda in 1986 in Japan. Although they have progressed much in their concepts and designs, in which a distal camera is attached at the point, and the image comes onto the computer, and you can take the lavage, you can take the sampling through the biopsies and all. But IP has changed much after the success of EBUS, which is called as endobronchial ultrasounds. In endobronchial ultrasounds, there is an ultrasound attached at the distal part of the trachea, bronchoscope, through which you can visualize the mediastinal lymph nodes which are near the tracheal wall, near your airways, and any mass or any tissue which is near your airways. It gives a real-time imaging, and plus you can also take the samples from there, and you can aspirate whatever sample is there, and that sample can be sent for the pathological tissue evaluation. It is basically done for your diagnosing diseases, mainly tuberculosis, sarcoidosis, and other any malignancies like lymphoma. Like EBUS, we can also do the EUS, endoscopic ultrasounds also. Another thing which has changed the IP is the rigid bronchoscopy. In rigid bronchoscopy, it is a rigid scope in which we go through the mouth and into the airways. For rigid bronchoscopy has both diagnostic and therapeutic measures. For diagnosing, it can be done for cryobiopsies from the lungs. In cryobiopsies, we use a cryoprobe to biopsy from the lung parenchyma. Cryobiopsies have changed how we look the ILDs. ILD is an interstitial lung disease in which your lungs fibrosed. It consists of multiple types of the diseases, and for which we need to evaluate which type of disease your patient has, and biopsies gives the best results. If we compare it with the wet surgical biopsies, this cryobiopsies is a daycare procedure, and the patient can be admitted in the morning and can be discharged by the evening. And post biopsies, these tissues can be sent for the pathological studies. It has significantly decreased the morbidity and mortality if compared with the surgical biopsies. Other is we use rigid bronchoscope for therapeutic measures in lung cancer patients. Many of our patients of the lung malignancy or from the malignancy from the other organs who develops airway obstruction, and it lands up in critical airway narrowing, in which their lumen of the airways decreases in size, and they started feeling breathlessness, cough, and sometimes they start producing sound which is called as stridor. All these patients require therapeutic measures to increase the lumen of their airways, and many of these patients require laser to dilate their airways, plus they may require the stents also. So now IPs have changed from the diagnostic to the therapeutic measures. Most of the patients will come on oxygens, and after putting the stent or opening the airways, they will go at home without oxygen. Although a palliative measure, but it gives immense relief to the patient who is breathlessness. Other intervention pulmonology thing which comes into is pleuroscopy, or called as medical thoracoscopy. In medical thoracoscopy, we go into the pleural cavity. We evaluate the pleura. In most of the cases which we require pleural thoracoscopy is pleural effusions. Pleural effusions can be recurrent, or it can be because of some diseases like tuberculosis, malignancies, or some undiagnosed pleural effusions in which are filling up again and again. In this patient, we create a window or a hole into the chest cavity through which we insert our endoscope and visualize the pleura. And we can take the biopsies also. Post procedure, we usually put a tube there and it drains all of the fluid which is present into the pleural cavity. Fluoroscope can also be, or thoracoscope can also be used to break the adhesions of the pleural cavity so that lung can inflate. Plus, in some patient, you can also put the talc to do the pleurodesis so that patient does not have recurrent pleural effusion. As I told you, IP has changed, but it was 30 years back. Another treatment which has come is bronchial thermoplasty. It is also a therapeutic measurement for bronchial asthma patients. In bronchial thermoplasty, there is a catheter through which we give radiofrequency ablation to the smooth muscles of the airways. Smooth muscles are the most common muscles which causes the spasm in the asthmatic patients, and this feels breathlessness, cough. Bronchial thermoplasty is a treatment for the patients who are difficult to control or who are called as severe asthma patients. Bronchial thermoplasty significantly decreases your daily ICS use, plus steroid use, and other medications. It dilates your airways and patients start feeling better. It occurs in three different settings at the three different parts of the lung. So each therapy of bronchial thermoplasty will be given after 3 weeks and will be continued for 6. Total treatment will continue from 1.5 months. Initially, when IP, interventional pulmonology, was started, it was more of a diagnostic procedure. Gradually, it has taken a lead into the therapeutic measures. And in future, we are hoping for a treatment for asthma and COPD patients. In COPD patients, sooner or later, some endobronchial valves will also come into the market for COPD patients. COPD patients develop hyperinflation of their lungs, which there's an increase in the lungs caliber. So all these patients, in many these type of patients, we can put the valves to decrease the lung caliber so normal lung can ventilate properly. Maybe in future we will see, although these such valves are present in the outside world, like in Europe and other countries, but sooner or later it will be available in our country also. Another therapy for COPD patient is a vapor therapy. Is about to come into the market, in which we are going to burn the tissue in the lungs to decrease the recurrent exacerbation of the COPD patients. These patients develop again and again increase in the symptoms with the weather change, or maybe the dust exposure, or maybe because of some infections. So with these patients, we are going to give them a better therapy so that these exacerbations can be decreased. Thank you, and I hope we can provide better treatment and everything for our future patients.